So good afternoon, everybody. I'm Jonathan Leach. I'm a general practitioner here in Worcestershire, and I'm Honorary Secretary of the Royal College of General Practitioners. So this is one of a number of webinars we've been doing, particularly focusing on the effects of COVID-19, as we're obviously experiencing that across the UK. What we'll be covering in this webinar is some clinical aspects, particularly around children, how the illness is affecting children, the paediatric inflammatory multisystem syndrome. We'll be covering shielding, also very importantly, non-COVID illness, which has been a concern. And then we'll be looking at some of the wider aspects of COVID on children and then looking forward. We'll also have some information about resources. And then at the end, as Bernard says, we'll be having a question and answer session. So please feel free to put those in the chat and we will actually, let's see what we can do to pick those up. So what we're going to do to start with, I've got a very experienced panel. So we're going to hand over to my panelists to introduce themselves. So we'll ask Alison to introduce herself, then Simon, and then Mike, Dr. Mike Linney, who is a consultant paediatrician in Portsmouth, to then move us into the first part. So I will see you at the end. So Alison, if you'd like to introduce yourself, then Simon, then Mike. Thank you very much.
Thanks, Jonathan. I'm Alison Tavare. I'm a GP in Bristol, and I also work with West of England AHSN Academic Health Science Network as part of their patient safety team, and have a special interest in the appropriate identification of the deteriorating patient and the ongoing management. Thank you.
Simon Stockley. I'm a GP in the northeast of England. I'm the RCGP's lead for acute deterioration and sepsis, and I'm currently working on a piece of work about deterioration in children.
Thank you. And I'm Dr. Mike Linney. I'm a paediatric consultant. Jonathan, it's Chichester and Worthing on the south coast, not Portsmouth, but that's fine. We're happy neighbours. And I'm also a registrar for Royal College of Paediatrics and Child Health. And thank you very much all for inviting me to talk to you today on COVID and children. So yes, next slide, thank you. The question really given to me was, how have children presented with COVID-19 to primary and secondary care? And from the onset, I just want to stress two things. Firstly, there have been far fewer confirmed cases of COVID-19 disease in children than adults. So we've been collecting data through the NHSE RCPCH audit tool. And we collected data on about 200 children admitted, which we believe is about a fifth of all those admitted, which is only 1,000 children. Bearing that in mind with how many adults were admitted, it puts a risk of admission to hospital for a child under 18 as something like 1 in 20,000. So it's very different to what you're seeing in adults and the elderly. When I say under 18s, I really mean probably under 20s. Again, admission under 20s is very low, in total about the same numbers. And this is consistent across the world with 2%. So if you look on the right-hand slide, you can see how these children presented, and the commonest symptoms are fever, cough, lethargy, and further down on wheeze. So really very typical of how children present to your normal practice. The average age of these children is about 3. So firstly, as I said, the children are less infected, requiring less admission. And next slide, please. Thank you. And for those who are admitted, they take a much milder course. So 2 really important things. Less children are infected, about 1 in 20,000. And those who are infected, it's a far milder course than in adults. This is important as we go through the slide set. So looking at, again, from this cohort of 200 children, you can see that the vast majority, 80%, required no additional care apart from feeding and monitoring support. And that includes not requiring oxygen, so good saturations. Out in this number, about 2% were admitted to PICU. And this is very typical across the world. In a study in America in 46 PICUs, only 48 children were admitted with average age of 13. In the United Kingdom, from the PICANET data, we know that up to mid-June, only 71 children were admitted. So these are small numbers, but sadly there have unfortunately been a few deaths. The risk of death is about 0.01%. But in a pan-European study, across 137 million children up to the age of 18, there were 44 COVID deaths, which puts the risk of death as 1 in 3 million. So again, very different to your adult history. So next slide, please. So what did happen? So again, looking at the slide on the right-hand side, I really want to demonstrate to you that this is a very much an age-related condition. And you can see on the right-hand side that as you get older, going through the decades, the risk of admission, the risk of ill health, and sadly and unfortunately the risk of death increases rapidly. We're seeing very few unwell children. But what did happen was we had the collateral effects to children, the risk of social isolation, the risk of late presentations, the social vulnerability. So really, even though children for the disease themselves weren't affected, they were very much affected by the situation and what was happening to their families. I think I also want to add at this stage is that evidence is building that children are low transmitters. So when we look at surveillance data, it seems rare that children transmit to adults. And actually, surveillance data also strongly suggests that the number of children infected is lower than we'd expect. But you've heard about this, but then as this was coming on, we heard in March when things were quietening down of some new unusual cases presenting to us. This was children presenting with really a very severe fluid-resistant shock, which I'll talk to you about next. So next slide, please. So this is paediatric inflammatory multisystem disease or disorder, something that we've not come across before. It's a severe inflammatory event. And we first heard of it really in early April. Children presenting with persistent fever and non-specific symptoms, which include abdominal pain and diarrhea, vomiting, cough, sore throat or confusion. They often had a rash and other signs consistent with a severe inflammatory condition. These children required PICU admission. For all these patients who we recognised, the differential diagnosis included severe sepsis, toxic shock syndrome, and severe Kawasaki syndrome. We believe around 200 to 250 cases were admitted to United Kingdom hospitals. The Royal College of Paediatrics and Child Health with BPSU are doing surveillance on this, and we'll have all the details of all these admitted patients soon. Like Kawasaki syndrome, who a few of you will remember and recognise, there's an association with coronary aneurysms, and about 14% of the children admitted to PICU did have some coronary aneurysms detected. It's important to recognise that outcome for these is very much improved with early recognition and aggressive anti-inflammatory therapy. It's very important to notice also that there was a clear grouping with a higher risk in Black and Asian communities. Thank you. Next slide, please. There was a temporal association with COVID-19. So as you can see, the peak of admissions to PICU, which happened in the week around about the 27th of April onwards, was about 4 weeks behind the peak of COVID. So this is very much seen as a post-infectious disease, as similar we see with perhaps Kawasaki syndrome, Hemlock-Schönlein purpura, and other post-infective events. Thank you. Next slide, please. So how do they present, and what's important, and what does it mean to you? Well, first of all, the key really is recognizing that it can be linked with coronary aneurysms. So we do want to detect these children as they come through. In this group of children, however, they were severely unwell, and every child was picked up via the normal pathways. You're seeing in front of you a very unwell child. You're seeing in front of you a child who might have severe sepsis, perhaps toxic shock syndrome, and also a persistent fever with other signs and symptoms that would cause you concern. I don't know how many of you come across Kawasaki syndrome. You might remember it from back in your medical school days. 1 or 2 of you may have seen a patient. It's not common, but again, it's worthwhile remembering of this condition as well, and its link and its similar association to the multisystem inflammatory syndrome. These children present with persistent fever, conjunctivitis, cracked lips, strawberry red tongue, and lymphadenopathy. If you see a child with a constellation of these symptoms, no matter how well they may be, those are important patients to discuss with your secondary care. But in this situation, the multisystem inflammatory syndrome, in addition to these features, they were severely unwell. If you note on the right-hand side, even though we detected these patients very early, the total number was very few. Perhaps up to 200 patients were admitted to UK hospitals during this period. Thank you. Next slide. And the college produced some guidance, which is very easy to find just by putting in RCPCH and paediatric multisystem inflammatory syndrome. That guidance talked about case definition and the management of interest to everybody. Thank you. Next slide. So I'm going to move across to shielding. So let's go back to what I said at the beginning. In children, there seems to be much lower admission rates to hospital, and it's of a much milder condition. So that means that the shielding guidance that we originally thought was appropriate across all the spectrums, we can now revise. And actually for children, it's only really the most unwell children, the most with severe conditions would need to be shielded. As part of the surveillance data, we did look for those comorbidities, and we found that children with severe respiratory symptoms linked with neurological or genetic conditions, or perhaps oncology patients and post-bone marrow transplant patients have more risk of being admitted. But if you look at the slide, these are absolute numbers, and they're very small. So we're looking for patients perhaps who have neurodevelopmental delay, poor respiratory effort, and maybe difficulty in clearing secretions as our high risk group. We have excluded asthma as a risk. It's very hard to find any patients admitted in the UK with asthma with COVID-19. This evidence has been duplicated worldwide. Next slide, please. So what does this mean to you? And I'm sorry, GP Online, it doesn't mean this. You can be relieved that you're not going to contact all children on shielding lists throughout this summer. It's going to be a joint work between general practice and secondary care. And I think the really important thing to mention here is that we're looking at children with severe conditions. So those children need to be shielded, almost certainly will be under secondary care. So we're already instigating discussions between the secondary care clinicians and their patients, either to confirm that they need to continue to be shielded or whether they can come off the shielding list. This is really good news for many, many children, so they can return back to a normal life, to as much a normal life as is possible. Thank you. Next slide. So just to reiterate, only those with the most severe conditions will need to shield. The paediatric hospital specialists are really strongly believe will manage this group of patients and case by case. And examples will include those with immunosuppressive therapy or severe respiratory problems. Important to primary care is that it's extremely unlikely, if at all, that any child under sole GP care will need shielding. And this will include all those asthmatic patients you might be seeing. And I don't want you to feel that children on inhaled corticosteroids, long-acting beta agonists or leukotriene receptor agonists need to be shielded. It's really only those who are severely unwell, perhaps with reduced lung function, maybe daily oral steroids, would need to be shielded. So with that note, just to summarize, COVID-19, it's not affecting children severely, but the effects of the lockdown has been very, very demanding on children and their families. Thank you. And over to Simon.
Are sick, we should be looking for something other than COVID as a cause, because COVID is not making kids that unwell. So we'll be looking at case finding. We'll be managing queries from about schools and outbreaks and the impact of family isolation and economic impact on the family. But then we're going to be also asked about sick children, and these are probably the ones where we have as much concern, because we're trying to manage these remotely, and how are we going to do that in the context of COVID? So we know that kids are not big spreaders of the disease, but that is completely different to what we experience with flu and other upper respiratory tract infections. Next slide. So we've had the symptoms from Mike about COVID, and they're pretty much the same as they are for adults. We know that fever and cough and upper respiratory tract symptoms are in there. Difficult to know whether a child has a sense of taste or smell, particularly at a young age, but they're also getting fatigue, muscle aches, vomiting and diarrhea. We've got access to child testing, and it results in them needing to isolate. But it's important that there isn't another cause, and that's probably where we're adding value in determining if this child is unwell. There is probably another cause than COVID. Next slide. So how do we do? This child is sick. Obviously, we've got the red flags. Are they got a nasty rash? Are they fitting? Are they very breathless? But signs of sickness in children, it's rate and effort of breathing. In adults, we know that bronchospasm is not a major feature of COVID, and that appears to be the case in children as well. So the picture of using accessory muscles in sick people with COVID isn't the same. They're getting primary respiratory failure without bronchospasm. The extreme lethargy and difficult to rouse children are of concern. And are they hydrated? Are they perfusing? Are they passing urine? Physiology is probably important in determining sick children in general practice, although we're less sure. And oximetry it is important for any kind of respiratory disease. The NHSI in an alert in December 2018 reminded us that using an appropriate oximeter and probe on the appropriate part of the anatomy was important. Many of us have got what are sold as pediatric oximeters. As far as I've been able to determine, that the main reason for them being pediatric oximeters is because they've got a picture of a bear or other cuddly creature on the front of them, and it's difficult to find out which age group they should be used on and what size of finger they go down to. Better machines are available with specific pediatric probes and meeting all reasonable requirements. Unfortunately, they're significantly more expensive than the 40 quid probe on Amazon. Next slide. There are lots of tools to help GPs, but which one should we use, and are there any that are particularly better? We've got the nice sepsis guidance, which gives ranges of physiology in a red, amber, green rating. Nice fever guidelines under 5 does the same thing and starts from the principle that you must have a fever to be actually unwell, and we know that that's not always the case. About 50% of sick children don't actually have a fever. There are lots of pediatric early warning scores and systems used in hospitals. I've come up with 23 so far, and there are variants of those. There is work ongoing to develop a national early warning score for children for use in hospitals, and we're looking at as to whether there's something in that we could use in general practice or align to, but that is some distance away. And then we have the red flag systems of the Sepsis Trust, which some of you will know are the triggers in your clinical system that tell you to worry about sepsis. And I think we've all probably worked out that they're a bit oversensitive. And then, of course, you may have a local tool that your EMOR practice wants to use. It's very confusing. I would suggest that you get familiar with some of the values in at least one of them and use it as a guide to your clinical judgment, but not as a replacement for it. Next slide. So what do I actually do? I'm listening to my parents. I'm interested in the speed of change. Is this an experienced parent who is experiencing some extreme of unwellness that they're not familiar or comfortable with? I ask, is this child presenting in an abnormal way for them when they're unwell? Most kids have been unwell at some point, and parents are fairly clear as to what represents unwellness for them. Do I like the look of them? Clinician concern has the same predictive value of parental concern. So if you think they look sick, then they probably are, and that may be the most diagnostic test we've got. I'm always going to observe them for respiratory effort and rate. Are they perfusing well? And is their behavior differently? Are they handling differently? If I've got the opportunity to examine them, I'm going to do a top to toe examination in the sick kids. I'm looking for the rash actively. I'm actively looking for causes in the ears and throat, belly, chest, and the small corners that children hide difficult things in, like hernias and testes, should be remembered. What do I measure? I tend to measure this stuff so that I can spot change. So that the next doctor along the line has something objective to measure change against, because it may not always be me who sees them. So I'll tend to use oximetry using a decent probe, which gives me their pulse. I'm going to make some comment about respiration, and it may be as much as no respiratory distress. And I will take temperature, not because I feel that that is particularly diagnostic of anything. It's more so that I've got a record of it and I can see if it is changing. And I safety net patients, and that will be specifically telling parents what to look for rather than come back if it gets worse. One of the criticisms that we get leveled against us is that when a sick child has presented to a GP and the mum thinks that this is the sickest they've ever seen their child, that they don't really understand what was meant by worse. And if I have concerns, I will actually plan a review and book the child in. Next slide. And over to Alison, and let's hope it doesn't all fall over again.
Thanks, Simon. And thanks to Mike as well for kind of both of you giving an overview of experience of COVID in children. And I thought I'd just give a little bit more information about COVID and pregnancy in the unborn child. And I'd like to thank Anne Remmers, who is one of our local leads for the Maternity Neonatal Collaborative in the AHSN. And Anne is on this call, so if you do have any questions specifically pregnancy related, please post them and Anne can look at them for us. So the UK obstetric surveillance system was actually planned some years ago for this kind of situation, so that if there was going to be an epidemic, pandemic of any kind, they could look at the impact. And already they've looked at 427 pregnant women, although actually it's been updated to 1,000, but that's not been published at the moment. But the good news is that there's currently no evidence that pregnant women are more likely to actually contract COVID-19, need intensive care or die than if they weren't pregnant. And there's also no current evidence that there's an increase in miscarriage or second trimester loss. But there are the caveats. And the one is that, again, people who are Black or minority ethnic are more represented in patients who are admitted. Pregnant patients with problems are more likely to be overweight, obese, older, and also have a pre-existing comorbidity. So that does matter. That does matter to us as GPs in identifying who's at risk. And some of the other findings are of the women who gave birth, 25% were preterm, although fewer than 20 were less than 32 weeks. And as I said earlier, that there haven't been a significant number of stillbirths, but they have occurred, and obviously that needs to be looked at in more detail to know whether it's COVID related or due to another cause. And also of interest, 1 in 20 born had a positive test for COVID-19. The significance of this isn't known, but of course now we are aware that children are less likely to be spreaders, so that may be clearer. Next slide, please. Thank you. So with that information there, what should we be doing as primary care clinicians? And I think one of the things we've got to be aware of is that if a woman is pregnant and presents as unwell, we've got to be aware that she could be at greater risk, partly because women aren't going to be presenting in the same way, and we know that quite a few are not seeing their midwives because some of the appointments they don't want to go to because they can't take their partner with them. So, if they've got reduced fetal movements, perhaps before they'd have gone early to the hospital and now they're later presenting. We should also be aware that women may be socially distancing. We need to look at the risk factors, as I've said earlier. And then something else that I think we need to highlight is that one of the increasing evidence for COVID is that people who've had COVID, for whether pregnant or not, are at the much increased risk of thromboembolic disease. So they may come back on thromboprophylaxis, but if a woman is acutely short of breath, it could be COVID, but could it be a PE? And then thinking about the baby, I was pleased to see that COVID is not a contraindication to breastfeed, and I've attached some guidance later. It's also helped, as Simon said, we need to be providing safety netting information, and again, that's in the resources. And then something else that we should really be looking at is making sure this 6 to 8 week check happens. We want to make sure our kids are having their hips checked, their eyes checked, that they've not got maldescent to the testicles. And we also need to make sure that routine immunisations are taking place. There's already evidence that MMR's uptake has been reduced. And then something else which is slightly softer perhaps, but I think is important for us going forwards, and it was a story shared with me by a local midwife who's describing how one of her patients delivered a stillborn baby, nothing due to COVID. And she said how difficult it was because she couldn't look after that woman in the normal way. She couldn't give her a big hug. And I think, we could well be seeing the impact on our patients' mental health going forward. I have referenced the Royal College of Obstetrics guidance at the bottom of the slide if you want to look at it in more detail. Next slide, please. So Mike mentioned earlier the kind of concerns about the reduction in emergency presentations. And this data comes from the RCPCH, so thank you to them for supplying that. And it's from returns from the EDs. And they started collecting it in April. And as you can see, the blue part of the chart is actually a decrease in presentations to the emergency department compared to the same week last year. And there really has been quite a significant reduction in presentation. What impact does this have on kids? So the paediatric emergency research team led by Damien Rowland from Leicester actually looked at this in more detail and found that actually delayed presentations of very sick kids are fortunately rare, and that also parents are responding to red flags. So we as GPs need to be sharing safety net information, and we also need to reinforce the message that the NHS is open. And again, I've included this really excellent advice from the RCPCH. We could text it to our parents, any contacts. If they've got it on their phones, it'll be easy for them to have a look at it. Can you put it on your website so parents can quickly find it? Thank you. Next slide, please. So Damien helpfully found that actually significant harm from delayed presentations is rare, but it does happen. And again, this is more information from the RCPCH, that sometimes the delay is in acute new conditions, at other times it's exacerbation of long-term conditions. And they've also highlighted the top 12 causes for this. And I just wanted to look at one of them, appendicitis. So late presentation. Is that because parents are not taking their child to the GP? Is that because they're not going to the emergency department because they're frightened that a child is more likely to get COVID? Is it that they think the symptoms are related to COVID and they're going to manage it at home? Or also, and I just kind of think about it as the GP, is that many of us have that kind of mantra that if we see a child 3 times, we get advice. We might discuss them with a colleague, we might discuss them with secondary care colleagues. And if people are presenting the same way, then we've lost that 3 strikes and you're out, or 3 strikes and you're referred way of managing a patient. So just think whether we could be playing a part. We don't know. This needs to be looked at, and I'm certainly aware the team in Plymouth Ask Sniff team are looking at it. But the one I really wanted to highlight here, or the 2, are the non-accidental injury and the safeguarding, and just to look at those in more detail. Next slide, please. Lots of worries have been expressed about the effect of COVID on our children and young people, and the reasons were twofold. One, that far increased pressures, that kids are being at home, they're not having contact with their friends, family pressure, financial pressure, loss of employment for parents. But also there's been that loss of oversight by teachers, by counsellors, by other members of the family. They're not perhaps aware of what's going on. So those were our concerns, and evidence is starting to emerge that there is some basis for these concerns. The National Domestic Abuse Helpline run by Refuge have had a significant increase in calls and a 700% increase in web traffic. Calls to Childline have increased, and they've provided 7,000 counselling sessions when COVID-19 has been mentioned since January. Significant increase. And Joy Shacklock, who's the RCGP lead for safety netting, was telling me how she's very concerned about manipulative behaviour by abusers. So if somebody is an abuser, they may refuse entry to social workers because saying that there's COVID in the house, or they may say somebody's shielding. And there's this recent paper, letter published in the Archives of Disease and Childhood, showing that already there's been a dramatic decrease in numbers of children seen for child protection assessments. There's lots more information on the RCGP website, and Joy Shacklock's got a webinar next week. We'll post a link in the chat, so please register for that. The last one on adult safeguarding was excellent. Next slide, please. And as part of these discussions that I've been having with colleagues, I've had lots of documents shared, and this came from Katie Melbourne, a paediatrician in London, which I found really thought-provoking and really quite sad. Small numbers, but if you have a look at this, 90% of young people saying that COVID has had significant impact on their some impact on their mental health, and for many of them it's significant. They miss their life, they've lost contact with families, friends, that has ups and downs. It's not negative for everybody. Some people it's closer than ever, but again, we need to be aware of that impact in the long term. Have you got easy resources on your website? Can you signpost young people to support? What can we be doing for this group going forwards? Thank you. Next slide, please. And it's that looking forward that I want to highlight, because we do need to be helping and supporting our children and young people getting back to this some sense of normality. How can we do that as GPs? How can we return to core general practice, make sure that our kids are seen, make sure that their immunisations are done, pick up what's not been done? How many of those kids missed a 6-week check? Which children haven't had their immunisations? However, it's also an opportunity to build on the learning. We're never going to be the same as GPs. We've got so much more capability to deliver remote consultations. When's it appropriate? When's it not appropriate? We have recently, this week, they've launched the intimate examination guidance, and we will be able to share that document afterwards. And then other learning, can we, now that we can consult digitally, can we have multidisciplinary team meetings? And I read one GP describing last week that for the first time he'd been able to go to a safeguarding meeting because it was held on Teams. So that's a huge positive. And can we also start having multidisciplinary team meetings with our secondary care colleagues? And again, Katie, my colleague in London, was describing her doing that. So going forward, let's build on what we've learned and share it. And so Gail Allsop, who's hopefully on this call, is compiling top tips from GPs, building on the learning, sharing good practice. So if you've got any ideas, please post in the chat so that we can identify them and work with the RCPCH to have a document that all of us can have to use to reference for the future. So thanks very much. Next slide, please. These are just a few resources, just highlighting some of them. The slides will be shared afterwards. There are lots of links, but obviously we'll make these available for you. And I'd like to have the next slide, please, and actually hand over to Jonathan to sum up what we've done. Thank you, Jonathan.
Yeah, thank you very much. I hope you found that interesting. I'm not sure what happened to the technical side of that. We all got crashed out, but anyway, we hope we're all back now. So the key message is actually most children with COVID will recover. And most sick children don't have COVID-19. And I think those are probably the two main messages that to take from this. I and Mike have done a huge amount of work on shielding. And as we said, very few children actually need to shield. And that's obviously on the consequence that very few actually have major problems. And probably the main one for us in general practice is that they need to be under a paediatrician or should be under a paediatrician. So if they're just under primary care, they don't need to be shielding. And also that asthma by itself is very, very unlikely to be a problem unless they're on some of the highest level of medication, but again, would be under paediatrician. Again, as Alison said, pregnancy is not particularly a problem, but there are some higher risk groups. And also when supporting parents when asking for medical advice. As Joyce says, sorry, as Alison said, our excellent safeguarding lead, Dr. Joy Shacklock, who's a GP from Harrogate, done a lot of work around safeguarding, and that is a concern. And as Alison said, we've got a webinar, which I do commend to you next week. But actually, the main thing is actually that work needs to continue. We need to be seeing these children. We need to be assessing them. So that's where we go. And then finally, top tips would be helpful if you've got any ideas. So what we're going to do now is that we've got sort of about 20 minutes. We're going to do a Q&A session, and Catherine, thank you very much, has been noting what's coming up in the chat. And I think if I can invite all the panel members to come back up, hopefully it won't crash. And what we'll do is that we'll see what we can do to answer your questions. And can I particularly thank all the panel members?
Great, thanks so much, Jonathan, and all of the panel. And thank you for bearing with us through the technical challenges. Yeah, we've had quite a few questions, and I'd encourage people to carry on putting their questions in the chat whilst we start getting some answers. I wanted to start by asking about how what advice you would give to people about remote consultations. When is it really important to see a child in person during the time of COVID? Because obviously quite a lot of healthcare interventions are being done remotely at the moment. What's your advice around that? Who would like to answer first?
Shall I start for secondary care, or do you want to start with primary care first?
You go ahead, Mike.
Okay. I think you've all got this. Again, going back to what I was saying earlier, almost when you're seeing a child at the moment, you need to take COVID disease out of it and just stick to what you really know. And if you're worried, if you've got that sense that you're worried, then you should see the child. And following on from Alison's point, I think it is that it's understanding the underlying message. If there's a concern about a vulnerable patient in a sort of a neglected situation or a remote situation, you need to see them. We're developing this more and more. I think it's easier in secondary care because we've got the geography, we've got the environment, and I do appreciate the difficulty in primary care. But I think my message is you probably know this. You've probably got the pickup points.
Simon.
I think for primary care, it's...
Simon, you've gone quiet.
But also remember that you need to go to video assistant referee, go to the video early and see if that gives you the reassurance and gives the parents the reassurance. But remember to do it safely. So the parent I had who was driving her kids home in the car probably couldn't do video at the time, but it's a good thing to consider, and it can reassure you very quickly.
Great, thanks. Jonathan?
So actually, I've been doing quite a lot of this, and I can think of one young lady I was examining. So it was initially a telephone consultation. I switched it to a video. And what video allowed me to do was actually, she could see my face. I was chatting away and smiling like this. And actually, I could see her. And then we turned to her daughter. And what that allowed me to do, I could see firstly that her daughter was awake and she was alert. Her daughter, who was quite young, thought it was wonderful to be able to stick her tongue out at the doctor. But actually, there was some method in the madness to that, in that I could see that she was cognitively working. I could see what her colour was. I could see what she was well hydrated. I then gently asked her mother just to slightly lift her t-shirt so I could then see respiratory rate. I actually taught the mother how to do her pulse rate, actually just by holding up this, or if it was a younger child, I'd be doing a brachial pulse. So actually there's a huge amount that we can do just using video. And actually I quite often will be teaching people how to take these measurements. And it's from that, I would then be able to see whether or not I'm happy with that a clinical decision can be made, or alternatively, whether or not that child then needs to be seen.
Great, thanks. We've got quite a few questions that have come in about the specifics around either diagnostics or symptoms. Does child testing, I think this came up during your talk, Simon, does child testing give valid positive or negative results, or can it have false results due to different immune reactions in children?
Can I jump in instead? Is that possible?
Yeah.
The difficulty with the testing is to do with the false positives and false negatives. And currently, with a very low incidence, if you get a positive result, it's probably a false positive more than being a true result. So child testing, if the numbers increase, might be clinically helpful, but at the moment it's not clinically helpful in primary care. What's really important to us is testing around surveillance around opening of schools, not because we're concerned that the opening schools will cause increase in infection rate. We want to prove that it doesn't. So that's why we want testing. We want testing around schools to demonstrate their safety in reopening.
That's really helpful to know. Someone else asked about how COVID can cause, they understand that COVID can cause all sorts of rashes in children, including a very chickenpox-like rash. Should kids with any of these rashes be isolating since they can't be tested for a rash?
I'll come back in again. The risk of you seeing a child in front of you with a rash being linked to COVID is probably extremely low, really, really low. So, and secondly, the risk of transmission, we're thinking also is low in children. The evidence is loose in coming out, but the more it comes out, the more it's showing transmission is lower. So those two reasons, my risk assessment is shielding, sort of isolating these children is probably not really helpful to them or their family. Including in that, if you then isolate every child with a rash, you're going to cause more problems than myself and Jonathan have hopefully sorted with shielding. So my answer is no, you don't need to.
Great. How long can a COVID fever last? If there's nothing else to worry about, when with a child with COVID fever, expect that fever to go? Because we know that in adults that can last several weeks.
So we're probably not seeing that duration in children. But again, keeping going back to the numbers, our evidence is really low because it's only on we've only got a small number of children to look at. We're thinking the incubation period is about 2 to 10 days. They came in with fever, but the length of stay was relatively short. So actually, we can probably say the duration of fever is short. What I would go back to in terms of the inflammatory syndrome, which again is very, very rare, if you've got a child with a persistent fever who also is unwell in front of you, then I would discuss that with secondary care.
Simon?
Yeah, I would emphasize that if you've got a child who's got a persistent fever, certainly at the present time and with our knowledge, you're looking for another cause. And if that's a long time for your other cause, am I missing a child with appendicitis? Is there something else going on here? Should be the first thought, not is this explainable by COVID?
That's really helpful, thank you. Somebody else asked for a brief summary on Kawasaki linked with COVID and complications. Is that what you already covered, or is that a separate question?
It is what I covered, and it is complicated in a very, very brief one slide to cover the whole of that. You know, there's reams of articles on this. I think, in summary, we have a condition called Kawasaki syndrome, which we've had around for 45, 50 years, first discovered in Japan by Dr. Kawasaki, and it presents with a persistent fever with signs of inflammation, which is conjunctivitis, cracked lips, strawberry tongue, lymph glands, and a sort of spreading maculopapular rash. Pediatricians are very aware of it. If you've got anybody with 2 or 3 of those conditions with a persistent fever, they need to be seen in secondary care or discussed, because early treatment with immunoglobulins is very helpful and very protective. So we have Kawasaki syndrome, and then we have this pediatric multi-system inflammatory disease. It's got about 4 or 5 different names around the world. This contains some features of Kawasaki syndrome, and it has some of the outcomes, such as the coronary artery aneurysm, but it is different. But because it contains some of those features, its treatment is linked along the same lines. So treatment is early, strong anti-inflammatory treatment, high dose steroids, intravenous immunoglobulins, or biologics. So right. It's a spectrum of disease. What you would see in primary care would be a very sick child in front of you if they had this syndrome of PIMTS, looking like sepsis, toxic shock syndrome. You're not going to hang around. You're calling 999. And to reassure everybody on the call, all those patients I discussed earlier on, which were presented in London, and again, actually, I didn't thank Liz Whittaker, but I must thank Liz Whittaker for those slides and information. All those patients went through the normal pathway. Even before we knew about this condition, they went to secondary care because they looked unwell.
That's great. And somebody in the chat has said there's a good resource. The Paediatric Kawasaki Foundation have some good resources online if people want to look for more information.
Absolutely.
Right, somebody else has asked another question about the false positives, and if we're getting false positives as all children are coming into hospitals, how useful are being tested? How useful is that?
Whoa, big question. I think the use is a lot of use for us. I'll go to Simon in a second, but a lot of use for us is on surveillance, because we're going to plan for winter, so we need to know what's coming up. And I think even though there's a false positive, it's going to be comparing it to the previous as well. So the numbers coming in is going to help us. The issue of positive patients is for us is that there's a next question about PPE, which is a whole different discussion, and how that's planned for the winter is there's lots of discussions at the moment about that at national level, which fortunately both myself and Jonathan are involved with.
Great. Somebody has mentioned that they've been advised to avoid examining ears and throats during COVID. Is this still the case?
Thank you very much. It's on my to-do list. A really, really good question, and it has caused some questions recently in the last week. I've had quite a few points on this. Let's go back to the beginning. When COVID first came out, we were learning at the time. There was a huge concern about staff safety as well as obviously patient safety. And there were some very concerning details of ear, nose and throat surgeons collecting COVID and unfortunately dying from COVID disease, which we think is related to a tonsillar type approach. We don't know exactly what it was, but a tonsillar approach. It was decided pretty rapidly that actually having a child with potential COVID coughing in your face wasn't a great idea. And even though it was never a PHE definition of an AGP, a number of us at the college with British Paediatric Allergy, Immunology and Infectious Diseases Association, plus ENT, felt it would be very, at this stage, until we got more evidence, we need to gown, glove, shield ourselves. So when it first came out, we were full PPE for an AGP procedure. We are at this moment rewriting that, and Kate's on the call with me at the moment, is doing that with me. And our likely advice, waiting for ENT to say so, will be wearing, to do a tonsillar approach now, I think it's appropriate to wear a surgical mask, a visor, and gloves. And that's where I think we're going for at the moment. What I don't want to have to happen is that patients get referred from primary care to secondary care for a tonsillar examination. Clearly, that's not helping anybody, primary care, secondary care, or the patient. So that needs a bit of playing around with, but that's what we're heading for. So simple answer, we're moving on, new approach has started, and we should have that new guidance up, hopefully with me and Kate on it, and over the next day or so. Kate, end of the week? Possibly.
Great, thank you. There were a couple of questions about the mental health side of things and how that's impacting on children. And a question that was asked was, what's the most common impact of COVID-19 on the mental health of children, which must not be missed? And another question was about how to treat anxiety neurosis due to COVID fear in children. Jonathan, would you like to answer first?
Yeah, so we've been seeing lots of children, lots of patients generally. Sorry, that's the grandfather clock in the background. Is that we've been seeing lots of patients generally with increased anxiety, what we've been generally advising is the same sort of things that we would do normally. Actually, it's not different from normal. And a lot of this is particularly around some people who've been very focused on the news. And actually what we'd be suggesting, obviously, that now that social distancing has been relaxed slightly, that they can now go out, taking exercise, things like this. So there's nothing particularly radical. What we are also concerned about is perhaps often the slightly older age group, where, for example, they might have more serious things, beginning of more serious sort of mental health problems, that if their normal support systems around psychiatric nurses and people like that, they by definition have changed. There is some emerging evidence that actually, unfortunately, because those support systems have changed, they are actually getting more unwell. But our role as GPs particularly would be to provide general advice and as appropriate refer, but it is a thing which we are concerned about generally and specifically in children. Thank you.
Alison.
Thanks, Jonathan. I just wanted to add to that, was one of the things simple things we could do as a GP, which I briefly alluded, is actually making sure we've got information and resources on our websites, because it could be that somebody's anxiety is due to domestic abuse at home, domestic violence. Have we got the links to Childline? Because if you're locked down at home, it's difficult to do the searches. So if you know that you go on your GP website and it's very easy to there, if somebody then comes in, particularly if there's coercion, you know where you're going and you can say you're on a GP website. So it's something that we could all be thinking about.
What struck in the information that you presented, Alison, was the kind of disproportionate effect that, because COVID has been affecting BAME communities more strongly, that's then having an impact on the families and the children in particular, even if COVID isn't significant to those people, the impact of COVID is, and we've got to think quite broadly about this, haven't we?
We have, because it was 25% of the children of a Black and minority ethnic background had either had a relation who died or a close friend, and that was really quite thought-provoking, because it makes me wonder, when we see our patients for review going forward, it may not be something that we're going to ask, but should we be aware of that? Why are they consulting? Has something happened COVID related which is impacting on their mental health going forward?
Great, thank you so much. I think that's so important. And yes, we are now kind of coming to the end of our time. And so I'd like to finish with a question to you all about what are your thoughts on what we need to be thinking of beyond COVID? It's sort of coming up for winter. and new challenges there. COVID hasn't gone away, but in this current phase that we're approaching and the things that we should be thinking about now in relation to care for children for the busy clinician, which is the topic. Who'd like to answer first?
Shall I, Catherine, do you mind if I start? I go?
Go, Mike.
Thanks. Catherine, thank you. Thanks for that question. I think it's really important to remember that COVID is going to be here all the way through winter. We know that, that's obvious. And even though I've talked about the disease effect of COVID-19 on children, the management is going to be really difficult in terms of our patient flows. So we're going to have to find space on our wards for children with COVID, children with bronchiolitis, children with influenza, plus how many other diseases we want to add into that. And we're going to struggle with our cubicles over this winter. And that's really important for everybody in the whole pathway. It's important for PICU passing patients down the line, and important for primary care passing patients up the line. So we need a really efficient way of working with this. And I think the best way of doing that is we all have to establish good communications between secondary and primary care now. And we've got this summer to manage that. Yes, there are details to do with where we put patients, what PPE we wear, testing. Those things are happening. We're involved in those discussions. But what's going to be the most important is the fact that you as a primary care physician know who to call with a patient and they'll get good advice. And because we've got all this new way of working, I also set up multidisciplinary meetings. GPs can call me and video chat with me with patients in front of them, and we can decide then and know what to do. We need a totally different way, but it's going to change us for the better if we get this right now.
Great, thank you. Simon?
I was going to say two things. One is vaccination is going to be really important for all age groups, particularly children, because they will be the super spreaders of influenza should we get a bad turn with that. And secondly, I think we're entering uncharted territory as to what the effect of social isolation and masks will be on the general distribution of infective illness. So all the common diseases, we don't know what that's going to do to bronchiolitis or seasonal flu. We know that this year's seasonal flu ended 6 weeks early, very abruptly, around the 23rd of March. It just shut down. We don't know what's going to happen to things going forward, and whether that's going to have to adjust our diagnostic concerns.
Thanks. Alison?
Thanks. And I kind of want to echo what the others have said about getting normal practice. And I realised I didn't clarify the photograph on my last slide. And we need to be creative. And that tunnel that was shown on the previous slide was one of my GP colleagues at work. They've designed a tunnel so that you can have drive-through vaccinations. You know, is that what we're going to be doing? How are we going to be getting the flu vaccination started? Because we're not going to be able to have the Saturday scrum, which we used to have with everybody having a vaccination every 3 minutes, because it definitely wasn't socially distanced. If you've got any ideas, please put them in the chat. Please let us know, because we don't know what we're going to do, but we've got to do it differently.
Thanks. And Jonathan?
So actually, we're doing a lot of work actually trying to look at vaccination at scale, and we at the RCGP hopefully will be publishing something shortly. And I agree with everything everybody said. I think that the thing I was thinking about was also it's actually going to be really important to reassure parents about children going to school. I think that's a really, really important thing, that we need children to go to school, both for academic progression, but also for general health, because there's a concern that actually sitting around playing on a PlayStation, actually they're putting weight on. So there's an issue in terms of, the narrow in terms of, whether or not that perhaps increases their risk in terms of COVID-19, but actually for the rest of their life, that we actually have one of the highest rates of obesity in this country, which doesn't serve as well, and it particularly doesn't in an adult population. So actually we need to be supporting children to go to school, which means that we need to be explaining and supporting parents to allow them to go to school, which is probably the most important thing. So with that, I'm going to, at 4 minutes past, since we had an intermission, probably the way of putting it, I'm going to call this now. So particularly can I thank Simon, Mike, Alison and Catherine, and then other colleagues behind the scenes, Bernard, Annabelle, Kate, and everybody else. We've done a lot of work behind the scenes in terms of getting this ready. I hope you found it interesting. As I said, if you're welcome to tell your friends and colleagues about it. It will be on YouTube. It's free to access alongside the other webinars that we've done on COVID-19. So with that, can I thank you all very much, and a jolly good afternoon.